Hello, today's topic is tuberculosis diagnosis and deep diagnosis. Diagnostic methods of pulmonary TB. Radiologic study, acid-fast bacilli smear microscopy and culture, and molecular methods such as nucleic acid amplification testing, line probe assay, and GeneXpert. The key to the diagnosis of TB is a high index of suspicion. Diagnosis is not difficult with the high-risk patients. For example, a homeless alcoholic who presents with typical symptoms and a classic chest radiograph showing upper lobe infiltrated with cavities. On the other hand, the diagnosis can easily be missed in an elderly nursing home resident or a teenager with a focal infiltrate. Often the diagnosis is first entertained when the chest radiograph of a patient being evaluated for respiratory symptoms is abnormal. If the patient has no complicating medical conditions that cause immunosuppression, the chest radiograph may show typical upper lobe infiltrates with cavitation. The longer the delay between the onset of symptoms and the diagnosis, the more likely is the finding of cavitary disease. In contrast, immunosuppressed patients, including those with HIV infection, may have atypical findings on chest radiography. For example, lower zone infiltrates without cavity formation. You see here diagnostic algorithm for pulmonary TB. This is new guideline. A presumptive diagnosis is commonly based on the finding of acid-fast bacilli on microscopic examination of a diagnostic specimen, such as a smear of expectorated sputum or of tissue, for example, a lymph node biopsy. Although rapid and expensive, acid-fast bacilli microscopy has relatively low sensitivity, 40 to 60%, in confined cases of pulmonary tuberculosis. Most modern laboratories processing large number of diagnostic specimens use auramine, rhodamine staining, and fluorescence microscopy. The more traditional method, light microscopy of specimens stained with quinone of Sil-Nissen basic fuchsin dyes, is satisfactory, although more time-consuming. For patients with suspected pulmonary tuberculosis, 3 sputum specimens, preferably collected early in the morning, should be submitted to the laboratory for AFP, smear, and mycobacterial culture. If tissue is obtained, it's critical that the portion of the specimen intended for culture not be put in formaldehyde. The use of acid-fast bacilli microscopy on urine or gastric lavage fluid is limited by the presence of commensal mycobacteria that can cause false positive results. Definitive diagnosis depends on the isolation and identification of mycobacterial tuberculosis from a clinical specimen or the identification of specific sequences of DNA in a nucleic acid amplification test. Specimens may be inoculated onto egg or agar-based medium, for example, Lowenstein-Nielsen or Middlebrook, and incubated 37. Because most species of mycobacteria, including Mycobacterium tuberculosis, grow slowly, 4 to 8 weeks may be required before growth is detected. Several test systems based on amplification of mycobacterial nucleic acid are available. These systems permit the diagnosis of tuberculosis in as little as several hours, with high specificity and sensitivity approaching that of culture. These tests are most useful for the rapid confirmation of tuberculosis in persons with acid-fast bacilli positive specimens, but also have utility for the diagnosis of acid-fast bacilli negative pulmonary and extrapulmonary tuberculosis. In general, the initial isolate of Mycobacterium tuberculosis should be tested for susceptibility to isoniazid, rifampin, and ethambutol. In addition, expanded Susceptibility testing is mandatory when resistance to one or more of these drugs is found or the patient either fails to respond to initial therapy or has a relapse after the completion of treatment. Susceptibility testing may be conducted directly with the clinical specimen or indirectly with mycobacterial cultures on solid or liquid medium. Results are obtained most rapidly by direct susceptibility testing on liquid medium, with an average reporting time of 3 weeks. With indirect testing on solid medium, results may be unavailable for more than 8 weeks. Drug susceptibility testing. Highly reliable genotype methods for the rapid identification of genetic mutation in gene regions known to be associated with resistance to rifampin, such as those in RPOB and isoniazid, have been developed and are being widely implemented for screening of patients at increased risk of drug-resistant TB. Apart from the EXPERT MTB-RIF and EXPERT MTB-RIF Ultra assays, which as mentioned above, detect rifampin resistance, the most widely used tests are molecular line probe assays. After extraction of DNA from Mycobacterium tuberculosis isolates or from clinical specimens, the resistance gene regions are amplified by polymerase chain reaction (PCR) and labeled and probed hybridized PCR products are detected by colorimetric development. This assay reveals the presence of Mycobacterium tuberculosis as well as mutations in target resistant gene regions. Given the rapidity and accuracy of commercially available line probe assays, the WHO recommends that they, rather than phenotypic culture-based tests, may be used to detect resistance to isoniazid and rifampin when patients have sputum smear positive specimens or a cultured isolate of Mycobacterium tuberculosis. A similar approach has been developed for second-line anti-TB drugs, such as the fluoroquinolones and the injectable drugs kanamycin, amikacin, and capreomycin. Therefore, second-line line probes assays are now recommended by the WHO as the initial test for rapid detection of resistance to the fluoroquinolones or the second-line injectable drugs in isolates from patients with confirmed resistant TB or MDR TB, rifampin resistant TB or MDR TB. The use of the rapid test MTB RIF EXPERT has expanded substantially since 2010. 4 and 8 million test cartridges were produced in 2014 by 116 low and middle income countries. By 2015, 69% of countries recommended using EXPERT MTB-RIF as the initial diagnostic test for people at risk of drug-resistant TB. In 2013 and 2014, WHO issued interim guidance on the use of bedaquiline and delamanid. By the end of 2014, 43 countries reported having used bedaquiline as part of treatment for MDR-TB. Here you see EXPERT MTB-RIF testing detection of TB and resistance, rifampin resistance. Genotype MTB-DR plus Hain test looks like this slide you can see. And genotype MTB-DR SL, detection of TBD, and genotype MTB-DR test, genotype MTB-DR ever 2 and 0 test. Radiographic procedures. The initial suspicion of pulmonary tuberculosis is often based on abnormal chest radiographic findings in a patient with respiratory symptoms. Although the classic picture is that of upper lobe disease with infiltrates and cavities virtually and radiographic pattern from a normal film or a solitary pulmonary nodule to diffuse alveolar infiltrates. And a patient with IRDS may be seen. In the area of AIDS, no radiographic pattern can be considered pathognomonic. CT may be useful in interpreting questionable findings on plain chest radiography and may be helpful in diagnosing some forms of extrapulmonary TB, for example, POTS disease. MRI is useful in the diagnosis of intracranial tuberculosis. Frequently, patients with radiographic abnormalities that are consistent with other diagnoses, for example, bronchogenic carcinoma, undergo fiber optic bronchoscopy with bronchial brushings and endobronchial or transbronchial biopsy of the lesion. Bronchoalveolar lavage of a lung segment containing an abnormality may also be performed. In all cases, it is essential that specimens be submitted for molecular testing with the expert MTB RIF assay, mycobacterial culture, and acid-fast bacillus smear. Invasive diagnostic procedures are indicated for patients with suspected extrapulmonary TB, in addition to testing of specimens from involved sites, for example, CSF for tuberculosis, meningitis, pleural fluid, and biopsy samples for pleural disease. Biopsy and culture of bone marrow and liver tissue have a good diagnostic yield in disseminated or miliary TB, particularly in HIV-infected patients, who also have a high frequency of positive blood cultures. Cavitating malignancy infections, pulmonary bacterial abscess, cavitating pneumonia, post-pneumonic pneumotoxella. A thin-walled pneumotoxella is not really a cavity, but when infected, can be thick-walled. Septic pulmonary emboli, other rare infections. Non-infective granuloma, granulomatosis with polyangiitis, rheumatoid nodules, vascular pulmonary infarct, trauma, pneumotoxellus, congenital, not to cavity, congenital cystic adenomatoid malformation, pulmonary sequestration, bronchogenic cysts. Fungal, often febrile. Immunocompromised or elderly patients may be afebrile. Hill varicella pneumonia, miliary metastasis, sarcoidosis, pneumoconiosis, pulmonary hemosiderosis, PCGiosis, hypersensitivity, pneumonitis, lung cancer, histiocytosis, multifocal micronodular pneumocyte hyperplasia, pulmonary alveolar proteinosis. Differential diagnosis is required in cases of prolonged pneumonia in upper and localization pneumonias in S6, post-basal segment, destructive pneumonia, atypical pneumonia. Here you see differential diagnosis between pneumonia and tuberculosis. In case of pneumonia, we have acute onset, chilling, high fever, severe intoxication, and sweating. In tuberculosis, subacute onset, low fever, night sweating, weight loss. In case of pneumonia, we have productive cough, sometimes rustling sputum. In tuberculosis, mild cough, sometimes hemoptysis, more than 3 weeks. Pneumonia, late inspiratory rales in the basal lobes, and in tuberculosis, physical findings are limited. Pneumonia, leukocytosis, granulocytosis, tuberculosis, mild anemia, and leukocytosis. Pneumonia, X-ray infiltrates in the basal lobes. And in TB, X-ray infiltrates mostly in the upper lobes. In case of pneumonia, good dynamics with the wide-spectrum antibiotics. And in case of TB, no effect with the wide-spectrum antibiotics. In case of pulmonary edema, we have presence of cardiac disease, heart failure, myocarditis. In case of biliary TB, no cardiac disease. Pulmonary edema, cough with pink, foamy sputum, chest pain, dyspnea, no fever. Biliary TB, dry cough, maybe meningismus, fever, dyspnea. Pulmonary edema, rales in the basal lobes. In biliary TB, mostly no crackles. In case of pulmonary edema, we have normal blood count and ESR. In military TB, leukocytosis, high ESR. And pulmonary edema, X-ray, 3 in bud, big foci in the basal lobes, unstructured hilum. And in miliary TB, miliary opacities in the upper lobe, structured hilus. And pulmonary edema, rapid contraction with glycosides and diuretics. And in miliary TB, no effect with cardiac therapy. Clinical findings for primary lung cancer for deep diagnosis. First, cough, most common symptom, 75% of cases. Weight loss, 40% of cases. Chest pain, 30% of cases. Hemoptysis, 25 to 30% of cases. Dyspnea. Pancreas tumor, superior sulcate tumor. Tumor is usually a primary SCC located at the extreme apex of the lung. Destruction of superior cervical sympathetic ganglion produces Horner syndrome, which means ipsilateral leg meiosis, ipsilateral anhidrosis, and also superior vena cava syndrome, paraneoplastic syndromes. Paraneoplastic syndromes, it means Eaton-Lambert syndrome. Associated cancer, we have small cell carcinoma of lung and common. In common, we have myasthenia gravis-like symptoms, for example, muscle weakness, antibody directed against calcium channel. Hypertrophic osteoarthropathy syndrome associated with bronchogenic carcinoma, and it's a periosteal reaction of distal phalanx, often associated with clubbing of nail. Nephrotic syndrome associated cancer is lung, breast, stomach carcinomas, and it's diffuse membranous glomerulopathy. Paraneoplastic syndromes, ACTH, Cushing syndrome, small cell lung carcinoma. ADH, CIADH syndrome of inappropriate antidiuretic hormone secretion is the small cell lung carcinoma. Antibodies against presynaptic calcium 2 plus channels at NMG. Lambert-Eaton myasthenic syndrome, muscle weakness, small cell lung carcinoma. And PTH-RP, hypercalcemia. We have hypercalcemia in this case, and it causes squamous cell lung carcinoma. Now about TB treatment and outcomes. TB treatment, DS-TB treatment with first-line drugs and rifampin-resistant MDR-TB treatment, standard long treatment for rifampin-resistant MDR-TB and short treatment for MDR-TB. DS-TB treatment of drugs susceptible is provided by first-line TB drugs, isoniazid, H, rifampicin, R, ethambutol, E, and pyrazinamide, Z. This course is called 2-IH-RZEE or 4-HR, daily during the 6 months based on DOTIS, directly observation short course strategy. First-line anti-tuberculous drugs. First is isoniazid. Isoniazid is critical drug for treatment of both TB disease and latent TB. Isoniazid has excellent bactericidal activity against both intracellular and extracellular, actively dividing Mycobacterium tuberculosis. This drug is bacteriostatic against slowly dividing organisms. In treatment of latent TB, isoniazid is considered the first-line agent because it's generally well tolerated, has well-established efficacy, and it's inexpensive. Isoniazid is a prodrug activated by the mycobacterial CAT-G catalase peroxidase. Isoniazid is coupled with reduced nicotinamide adenine dinucleotide, NADH. The resulting Isonicotinic acryl and the NADH complex blocks the mycobacterial ketoano reductase known as INHA, binding to its substrate and inhibiting fatty acid synthesis and ultimately mycolic acid synthesis. You see here the STB treatment. How acts the isoniazid? Inhibits cell wall synthesis. Ethambutol inhibits cell wall synthesis. Pyrazinamide, exact target unclear, but disrupts plasma membrane, disrupts energy metabolism. And rifampin inhibits RNA synthesis. Isoniazid is the hydrazide of isonicotinic acid, a small water-soluble molecule. The usual adult oral daily dose of 300 mg results in peak serum levels of 3 to 5 mg in milliliter within 30 minutes to 2 hours after ingestion, well in excess of the MI6 for most susceptible strains of Mycobacterium tuberculosis. Isoniazid is metabolized in the liver via acetylation by N-acetyltransferase 2 and hydrolysis. Although isoniazid is generally well-tolerated, drug-induced liver injury and peripheral neuropathy are significant adverse effects associated with this agent. Rifampin is a semi-synthetic derivative of Amycolatopsis rifampicinica, formerly known as Streptomyces mediterranei. The most active antimicrobial agent available, rifampin, is the keystone of first-line treatment for TB. Introduced in 1968, this drug eventually permitted dramatic shortening of the TB treatment course. Rifampin exerts both intracellular and extracellular bactericidal activities. Like other rifampicins, rifampin specifically binds to and inhibits mycobacterial DNA-dependent RNA polymerase, blocking RNA synthesis. Susceptible strains of Mycobacterium tuberculosis, as well as Mycobacterium kansasi and Mycobacterium marinum, are inhibited by rifampin concentrations of 1 mg in milliliter. Rifampin is a fat-soluble complex macrocyclic molecule readily absorbed after oral administration. Serum levels of 10 to 20 mg in milliliter are achieved 2.58 hours after the usual adult oral dose of 10 mg/kg given without food. Adverse events associated with rifampin are infrequent and generally mild. Hepatotoxicity due to rifampin alone is uncommon in the absence of pre-existing liver disease and often consists of isolated hyperbilirubinemia rather than aminotransferase elevation. Ethambutol is a bacteriostatic antimicrobacterial agent first synthesized in 1961, a component of the standard first-line regimen. Ethambutol provides synergy with the other drugs in the regimen and is generally well tolerated. Ethambutol is bacteriostatic against Mycobacterium tuberculosis. Its primary mechanism of action is the inhibition of the arabinosyltransferases involved in cell wall synthesis, which probably inhibits the formation of arabinogalactan and lipoarabinomannan. Ethambutol is usually well tolerated and has no significant interactions with other drugs. Optic neuritis, the most serious adverse effect reported, typically presents as reduced visual acuity, central scotomia, and loss of the ability to see green, or less commonly red. Pyrazinamide, a nicotinamide analog. Pyrazinamide is an important bactericidal drug used in the initial phase of TB treatment. ITSM administration for the first 2 months of therapy with rifampin and isoniazid allows treatment duration to be shortened from 9 to 6 months and decreases rates of relapse. Pyrazinamide's antimicrobacterial activity is essentially limited to Mycobacterium tuberculosis. The drug is more active against slowly replicating organisms than against actively replicating organisms. At the higher dosage used previously, hepatotoxicity was seen in as many as 15% of patients treated with pyrazinamide. You see here DS-TB treatment outcomes. Cured pulmonary TB patients with bacteriologically confined TB at the beginning of treatment who was smear or culture negative in the last month of treatment and on at least one previous occasion. Treatment completed. A TB patient who completed treatment without evidence of failure but with no record to show that sputum smear or culture results in the last month of treatment and on at least one previous occasion were negative, either because tests were not done or because results are unavailable. Treatment failed. A TB patient whose sputum smear or culture is positive at month 5 or later during treatment died. A TB patient who dies for any reason before starting or during the course of treatment. Lost to follow-up. A TB patient who did not start treatment or whose treatment was interrupted for 2 consecutive months or more. Not evaluated. A TB patients for whom no treatment outcomes is assigned. This includes cases transferred out to another treatment unit as well as cases for whom the treatment outcomes is unknown to the reporting unit. And treatment success, the sum of cured and treatment complete. The resistance to rifampin is associated with mutations in the RPOB gene in 95% of cases. Led to isoniazid with mutations mainly in the KATG gene, 50 to 95% of cases, and the INHA gene promoter region, up to 45%. Led to pyrazinamide in the PNCA gene, up to 98%. Led to ethambutol in the AMB gene, 50 to 65%. Led to the torque hormones in the GRA and GRB genes. Led to aminoglycosides mainly in the RRS gene, up to 18%, with the C20T mutations as the most common mutation in the ACE promoter region associated with aminoglycoside resistance. The development of drug-resistant TB almost invariably follows monotherapy. Drug-resistant TB may be either primary or acquired. In primary drug resistance, the patient is infected from the start by a drug-resistant strain. Acquired resistance develops in the infecting strain during treatment. Here you see factors contributing to poor TB treatment outcomes. Inappropriate guidelines, non-compliance with guidelines, absence of guidelines, poor training, financial disincentives, poor patient education, no monitoring of treatment, poor management of adverse drug reactions, poor treatment support, poorly organized or funded TB control programs. Inadequate supply or quality contains poor quality medicines, unavailability of certain medicines, poor storage conditions, wrong dose or combination, poor regulation of medicines, and patients, inadequate drug intake or treatment response. Lack of information, lack of means to adhere to treatment. Adverse effects, social barriers, HIV, diabetes mellitus, undernutrition, malabsorption, substance abuse, psychiatric conditions. Here you see percentage of new cases of multi-drug resistant, rifampin-resistant TB in all countries survived by the World Health Organization Global Drug Resistance Surveillance Project during 1994-2016. Contexts of drug resistance are monoresistance, resistance to one first-line anti-TB drug only. Polyresistance, resistance to more than one first-line anti-TB drug, other than both isoniazid and rifampin. Multidrug resistant MDR-TB is resistant to at least both isoniazid and rifampicin. Extensive drug resistance, XDR, resistance to any fluoroquinolone and at least one of the second-line injectable drugs, capreomycin, kanamycin, and amikacin, in addition to multidrug resistance. Rifampicin resistance, RR, resistance to rifampicin detected using phenotypic or genotypic methods, with or without resistance to other anti-TB drugs. It includes anim resistance to rifampicin in the form of monoresistance, polyresistance, MDR, or XDR. Even more serious is the occurrence of XDR-TB due to MDR strains that are also resistant to any fluoroquinolones and to any of 3 second-line injectable agents, amikacin, kanamycin, and capreomycin. Creation of drug-resistant TB can be prevented by adherence to the principles of sound treatment, inclusion of at least 2 quality-assured bactericidal drugs to which the organism is susceptible, use of fixed-dose combination products, supervision of treatment with patient support, and verification that patients complete the prescribed course. Transmission of drug-resistant strains can be prevented by implementation of respiratory infection control measures and by early detection of people with active TB followed by immediate initiation of treatment with an effective regimen. For the treatment of patients with isoniazid-resistant diseases, it's recommended to use a combination of rifampin, ethambutol, pyrazinamide, and levofloxacin for 6 months. Injectable agents such as streptomycin and kanamycin are unlikely to play a role in the treatment of most isoniazid-resistant TB cases. MDR-TB, in which bacilli are resistant to at least isoniazid and rifampin, is more difficult to manage than is disease caused by drug-susceptible organisms, because these 2 bactericidal drugs are the most potent agents available and because associated resistance to other first-line drugs as well, for example, ethambutol, is not uncommon. Therapy for MDR-TB is therefore more complex. It's based on limited evidence, is lengthy and potentially toxic, uses drugs of limited efficacy, and is much more expensive than treatment of drug-susceptible disease. For treatment of MDR-TB and all other rifampin-resistant TB cases in which isoniazid resistance is absent or unknown, 2 approaches are currently recommended by the WHO: a shorter standardized regimen of 9 to 20 months duration and a longer regimen of 18 to 24 months duration consisting of an optimal combination of drugs according to a standard design. Mycobacteriology laboratory services for drug-resistant TB programs. This is microscopy, expert MTB, RIF, line probe assays, culture of Mycobacterium tuberculosis, identification of Mycobacterium tuberculosis, drug susceptibility testing, phenotypic DST, and genotypic DST. Group A, fluoroquinolones, levofloxacin and moxifloxacin, bedaquiline and linezolid were considered highly effective and strongly recommended for inclusion in all regimens unless contraindicated. Group B, clofazimine and cycloserine or terizidone were conditionally recommended as agents of second choice. And Group C included all other medicines that can be used when a regimen cannot be composed with Group A and B agents. The medicines in Group C are ranked by the relative balance of benefit to harm usually expected of each. Here you see a grouping of medicines recommended for use in longer MDR-TB regimens. You see Group A include all 3 medicines: levofloxacin, moxifloxacin, bedaquiline, linezolid. Group B add one or both medicines: clofazimine, cycloserine, and terizidone. Group C add to complete the regimen and when medicines from groups A and B cannot be used: ethambutol, delamanid, pyrazinamide, imipenem, hilastatin, meropenem, amikacin, ethionamide, prothionamide, P-aminosalicylic acid. Torchinolones. Torchinolones inhibit mycobacterial DNA gyrase and topoisomerase intravenous, preventing cell replication and protein synthesis, and are bactericidal. They are also being investigated for their potential to shorten the course of treatment for TB. If torchinolones are well absorbed orally, reach high serum levels, and distribute well into body tissues and fluids, their absorption is decreased by co-ingestion with products containing multivalent cations, such as antacids. Adverse effects are relatively infrequent and include gastrointestinal intolerance, rashes, dizziness, and headache. You see here the MDR-TB treatment. Isoniazid inhibits cell wall synthesis. Thioamidis inhibits cell wall synthesis. Cycloserine inhibits cell wall synthesis. Rifampin inhibits RNA synthesis. PAS inhibits synthesis of DNA precursors. Torchinolones inhibits DNA gyrase. Cyclid peptides inhibit protein synthesis, and aminoglycosides inhibit protein synthesis. Oxazolidinose. Linezolid is an oxazolidinone used primarily for the treatment of drug-resistant gram-positive bacterial infection. However, this drug is active in vitro against Mycobacterium tuberculosis and NTM. Several case series have suggested that linezolid may help clear mycobacteria relatively rapidly when included in a regimen for the treatment of complex cases of MDR-TB and XDR-TB. Linezolid's mechanism of action is disruption of protein synthesis by binding to the 50S bacterial ribosome. Bedaquiline is a new diarylquinolone with a novel mechanism of action. Inhibition of the mycobacterial ATP synthetase proton pump. Bedaquiline is bactericidal for drug-susceptible and MDR strains of Mycobacterium tuberculosis. Resistance has been reported and is due to point mutations in the ATP-E gene encoding for subunit C of ATP synthetase. Adverse effects, QT prolongation. Here you see nitromisadole's novel complex mechanism of action inhibits cell wall synthesis and inhibits cell respiration. Macrolides inhibit protein synthetases, oxazolid inhibit protein synthetases, and Peyrols mechanism of action uncertain. The prodrugs delamanid and PA824 are novel nitrodehydroimidazooxazole derivatives that are activated by Mycobacterium tuberculosis specific flavin-dependent nitroreductases and whose antimycobacterial activity is attributable to inhibition of mycolic acid biosynthesis. And adverse effects are also QT prolongation. Clofazimine is a fat-soluble raminophenazine dye used primarily in the treatment of leprosy worldwide. It's currently gaining popularity in the management of MDR-TB and XDR-TB because of its low cost and its intracellular and extracellular activity. By increasing reactive oxidant species and causing membrane destabilization, clofazimine may promote killing of antibiotic-tolerant Mycobacterium tuberculosis persister organisms. In addition to antimicrobial activity, the drug has other pharmacologic activity such as anti-inflammatory, pro-oxidative, and immunopharmacologic properties, and adverse effects is also QT prolongation. Cycloserine is an analog of the amino acid D-alanine and prevents bacterial cell wall synthesis. It inhibits the action of enzymes, including alanine brachymas, that are involved in the production of peptidoglycans. Cycloserine is active against a range of bacteria, including Mycobacterium tuberculosis. Mechanisms of mycobacterial resistance are not well understood, but overexpression of alanine racemase can confer resistance in Mycobacterium smegmatis. Cycloserine is well absorbed after oral administration and is widely distributed throughout body fluids, including CSF. Cycloserine should be administered as dosed only with caution and with support from experienced TB physicians to patients with epilepsy, active alcohol abuse, severe renal insufficiency, or a history of depression or psychosis. Other medicines that are not included in Group A SIC are kanamycin and capreomycin, which were associated with poor outcomes when used and are therefore no longer recommended for use in MDR-TB regimen. Catifloxacin and high-dose isoniazid were used in very few patients, and thioacetazone was not used at all. Quality assured preparations of catifloxacin are not currently available following its withdrawal from the market due to concerns about dysglycemias. Thioacetazone is unlikely to have a role in contemporary longer regimens and is not currently available in a quality assured formulation. High-dose isoniazid may have a role in patients with confirmed susceptibility to isoniazid. Clavulanic acid should be included in MDR-TB regimens only as a companion agent to the carbapenems, imipenem, cilastatin, and meropenem. When used in this way, it should be given with every dose of carbapenem and it should not be counted as an additional effective TB agent. The duration of longer MDR-TB regimens. In MDR-TB patients on longer regimens, a total treatment duration of 18 to 20 months is suggested for most patients. The duration may be modified according to the patient's response to therapy. Condition recommendation were a low certainty and the estimates of effect. You see here criteria. Shorter MDR regimen, it's and the longer. You see in longer MDR-TB regimens, we have intensive phase duration up to 8 months, composition 4 or more second-line drugs. Continuation phase, we have duration 20 months or more, composition 3 or more second-line drugs. The intensive shorter regimen consists of 4 to 6 months of kanamycin, moxifloxacin, protonamide, clofazimine, pyrazinamide, high-dose isoniazid, and ethambutol. The shorter continuation regimen consists of 5 months of moxifloxacin, clozamide, pyrazinamide, and ethambutol. In MDR-TB patients who have not been previously treated for more than 1 month, with second-line medicines used in the shorter MDR-TB regimen, or in whom resistance to torhinolones and second-line injectable agents has been excluded. A shorter MDR-TB regimen of 9 to 20 months may be used instead of the longer regimens. And you see here the last slide of DR-TB treatment outcomes. Cured, we have outcomes. Cured, completed, failure, lost to follow-up, died, not evaluated. Cured definition is patient initially bacteriologically confirmed culture molecular tests who completed treatment and with at least 3 negative cultures in the last 8 months of treatment. AND does not meet the definition of failure. If there is a lone positive culture or smear reported during that time, and non-concomitant clinical evidence of deterioration. A patient may still be considered cured, provided that this positive culture is followed by a minimum of 3 consecutive negative cultures taken at least 30 days apart. Outcome completed. Patient who completed treatment AND has no signs of continued active disease. AND does not meet the bacteriological criteria for cure. Failure. Definition of failure is treatment terminated or need for permanent treatment change of at least 2 classes of anti-TB drugs because of one or more of the following. Lack of monitoring cultures converting to negatively by 6 months for MDR-TB. Resistance amplification to rifampicin or isoniazid, or to group 2 or group 3 drugs. Bacteriological reversion. A clinical decision has been made to terminate treatment early due to poor response or adverse events. These later failures can be indicated separately in order to do sub-analysis. Outcome lost to follow-up. Definition. Patient who interrupted treatment for 2 months or more. Patient who died on TB treatment or while awaiting TB treatment irrespective of the cause of death. The cause of death should be recorded. This is definition of died. The definition of not evaluated. Patient whose treatment outcome is unknown, including patient transferred out to another treatment. Thank you for your attention.